Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On today's podcast, I'm speaking to Dr. Stephanie Cook, the clinical lead for the Women's Health Hubs in Liverpool, a GP with a special interest in women's health and a director of the Primary Care Women's Health Society. In this conversation, Stephanie discusses how women's health hubs can bring care closer to home, slash waiting times, and help tackle health inequalities. And she explains how the Liverpool hub model works in practice. We also discuss the systemic barriers facing women's health services, including the lack of sustainable funding, the impact of removing women's health from the NHS planning guidance, and why better stewardship of resources is crucial to successfully shifting care from hospitals and into the community. GP Online has joined forces with 5 essential healthcare resources to create the MIMS Healthcare Network. Since 1959, our Haymarket healthcare titles have supported primary and secondary care audience across the UK through individual publications and specialist events. We're now entering an exciting new era with the launch of MIMS Healthcare Network, linking together our 6 leading media brands to serve the entire healthcare community as one. The MIMS Healthcare Network covers GP Online, GP Business, MIMS, MIMS Learning, MIMS Learning Live and MIMS Pharma. By bringing together these resources, we aim to provide a seamless experience for all healthcare professionals and the organisations that support and supply the UK health sector. The MIMS Healthcare Network, covering every aspect of primary care. For more information about our subscriptions, visit GPonline.com/subscribe. I'm really pleased to welcome onto the podcast Dr. Stephanie Cook. Stephanie is the clinical lead for the Women's Health Hubs in Liverpool, a GP with a special interest in women's health and a director of the Primary Care Women's Health Society. She was heavily involved with the design, development and implementation of women's health hubs across Liverpool, and that work has provided lots of material to support the development of women's health hubs across the country. Thank you so much for coming on the podcast, Stephanie.
Oh, it's a pleasure. Thank you, Emma.
So you're here to talk about women's health hubs and all things women's health. And so I thought I'd start off with the women's health strategy. So the government published its updated women's health strategy for England in April. And that strategy, basically, in the start of it, it said that the NHS is currently failing women. In the foreword, the former Health and Social Care Secretary, Wes Streeting, said that the NHS has a problem with basic everyday sexism and an appalling culture of medical misogyny. What do you think are some of the key challenges facing women seeking healthcare at the moment?
I would say, to start with, we always welcome any focus on women's health. We know that women have been underserved for many years. We know that gynecology is one of the worst hit specialties, and in many areas, including where I am up in the northwest, we see wait lists of around 12 to 18 months, sometimes before patients are seen. So these are incredibly long waiting lists. Patients are really suffering while they wait to be seen. And many of these issues, as we'll talk about in due course, can often be dealt with in the community by colleagues such as myself, GPs with an interest in women's health, ANPs, other healthcare professionals. So we welcome any focus, first and foremost. In answer to your question, what do we think are the challenges? Well, you raised the issue of medical misogyny and women being dismissed. And of course, that's important. With 1.5 million staff that the NHS has, there's always going to be a need to do things better. And there's always going to be a need to call out any of that happening, any misogyny, any dismissive attitudes towards. You'll have seen some of the campaigns such as Not Just a Period, all of these things, and issues such as menopause, endometriosis, all these other things coming to light. So I would acknowledge that that's important. But I would say, in my experience, having been a GP coming up to 20 years and qualified as a doctor coming up to 25, the main challenges are more around the system, the lack of funding, the lack of infrastructure to deliver these services out in the community, where we know time and time again, the government's own cost-benefit analysis and many similar reviews have shown that if we bring these services out into the community, it's better for women, it's more joined-up holistic care, we get better return on investment, we get reduction in wait lists, and we get better utilage of limited services. So my view is that although it's absolutely really important to call out medical misogyny, and that happens, it happens every day, of course it does, I don't think that that's what we're dealing as a primary barrier to women not getting the services they need. I think we have a grossly underfunded system. We only have so many resources to go around. We know that. But I think a lot of the barriers currently that we see that we're facing that are limiting women from accessing these much needed services are inefficiencies in the system, poor stewardship of current resources, lack of funding being held up in these block contracts in hospitals, which is, of course, a real challenge. And when you have underfunded services across the system, it's really hard to go and dip into a pot that's in the negative. And that's what many of the real challenges are. Of course, challenges to training and qualifications in many of these areas and teaching from med school to postgraduate to people doing their GP training. Of course, those are all issues. But I think primarily it's freeing up the resources so that we have, for every £1 spent on women's health hubs, we get a £5 investment. And similar stats that we see all the time. So I think it's about, one of my buzzwords is stewardship. So we don't have a lot of resources. So it's about using what we've got better. And unfortunately, we're not seeing the releasing of access to some of those resources so that we can spend them more carefully and free up sort of expensive secondary care appointments, which are better for the cancer care and the major operations. And, we don't need lots of menopause care to be waiting 18 months to be seen in secondary care. We don't need simple ring pessaries to wait a year or more for a poor little old lady with a prolapse not be able to get that support that many primary care clinicians can deal with. It's about better utilage, better stewardship, and enabling what is that 10-year plan, of hospital to community, that left shift.
Do you think the government strategy will actually help address some of these challenges around funding and resources and moving care out of hospitals into the community and women's health hubs?
I'll start with the positive and say that any focus on women's health is good. But unfortunately, going way back to 2022, when the first strategy came out, we then saw a small amount of funding went out into ICBs. That was 25 million, which worked out at 595,000 per ICB. Lots of challenges there because some ICBs are around 3 million size, some are under 500,000, so not necessarily evenly distributed per population. And then sadly, it wasn't ring fenced, and we saw many areas report back that significant amounts, sometimes up to as much as 50% of those pots, being not actually getting to the areas that they were meant to be sent to and being used for sort of overspend and debt, which is a real tragedy. Even so, some of those monies still went out, but it was non-recurrent. It was not ring fenced. And then, of course, we saw February last year when this was removed from the NHS planning guidance, which from my side of view as, primary care clinician and involved in a lot of these services, it just felt like a bit of a nail in the coffin, because if you take away that incentive to invest in these services, we cannot build sustainable services on non-recurrent funding. Now, I understand the principle of a little bit of pump priming, a little bit of here's a starter for 10, here's something to get you going, show a proof of concept, and then hopefully the powers that be, the ICBs, etc., will listen. But unfortunately, what we see is ICBs saying, well, we're overspent, underfunded in so many areas as it is. The government needs to fund these initiatives if they want them to happen. And we see the government, DHSE, often saying, well, ICBs have had their allocation, they need to spend their pocket money wisely. Sadly, the victims often in that is primarily the patients, but the women's health services, where we have shown time and time again, even areas non-recurrent funding, and they showed that there was savings, there was reduced wait lists, extremely high patient satisfaction. Still, we're seeing now many of those services that started out coming under threat because there is just nothing to support those pilots. Your question was, do we think we'll see an improvement as a result of the strategy? Well, there's good aims there and there's good focuses there. But unfortunately, without sustainable resources, and either the government has to put money in, or there needs to be steer and leverage on ICBs to proactively invest in these services and move out care, because it will save monies, because it will reduce wait lists, because it will be better for the whole system. But unfortunately, often out in the community, primary care services, and it's not only primary care that are doing hubs, but that's primarily the model that we're seeing nationally. We're a bit powerless.
You mentioned training and education. Do you think there's enough focus on women's health issues in undergraduate medical training and in GP training? Do you think GPs are given enough time to focus on women's health?
absolutely. I think we often do need more undergraduate training in health, and that is really important. And we need more patient education as well. And then in sort of GP training, I think that there's room for more, but what actually often happens is without the ability in primary care for us to have a slightly long appointment in order to do a gynecological examination, speculum examination, a swab if we need to, it's still extremely difficult, even if you've got the knowledge, to be able to offer the service that you're trained to do. I personally think one of the challenges we often see is I think there's lots of areas in general practice where people upskill. GPs with an extended role, colleagues with a specialist interest, and it's obviously across the scope, not just women's health, dermatology, and all sorts of other areas where people may have a specialist interest, to the extent that there are certain services that can be delivered at cost out in the community, but they've got to be reimbursed. And personally, I think the government struggles to understand this. They think if it can be done in the community, therefore it should be done with GP contracts. That's not what the GP step is. Menopause is an example. To be a menopause specialist, so we've got a couple of bodies that acknowledge menopause training. We've got the British Menopause Society and we've got the College of Reproductive and Reproductive Health that have their own training as well. But, to have one of those certificates or a higher certificate in menopause care is the sort of pinnacle of what you can get to in terms of becoming a menopause specialist. However, GPs cannot, in vast majority, unless they're in a commission hub that's pulled out commission out services, they cannot receive any income for it. And I think the government often struggles with the concept of if GPs can do it, they should be doing it on their own time and on their contract. They don't kind of get that general practice is often this eclectic, diverse community of healthcare professionals, many with some very interesting skills in different areas, minor surgery, other things, but they cannot deliver it on thin air. And yet the tariffs would often be smarties compared to, NHS contracts.
That's a really good point. One of the reasons I really wanted you to come on the podcast, because I was really interested in talking to you about all the work you've done around women's health hubs. And obviously I said at the start that you've been involved in setting them up across Liverpool. I mean, you're obviously very passionate about the role that they can play in improving women's health. So why do you think they're so critical?
Yeah, great question. So women's health hubs are really so highly valuable and have a critical role. I don't care what people call them. I don't care if they look a little bit different in different areas, but it's about bringing that care closer to home, reducing the wait list. It's better for patients. We've seen so much fragmentation, particularly in women's health. So many of us will be aware of what happened in 2012 with the Health and Social Care Act, which split the commissioning for contraception and gynecology. What that means in reality is that a woman can go to a sexual health service for a contraceptive coil, but if she was going for the same coil for heavy periods or HRT, she couldn't access it because it comes out of a different pot. And this happens time and time again, a woman needing to have an intimate personal examination to have a smear, and then she's got to go somewhere else for her contraception, somewhere else for her HRT. For many women, particularly in busy working lives, it's so hard to organise all of those appointments. It's not pleasant to have an intimate examination and then to have that repeated several times over when it all could be done in the one sitting. That holistic joined up care piece, obviously I'm biased, but I think primary carer, that's right up our street. We love doing that bit, that whole total picture. And we know our patients so well. And you might sort of see a patient of morning and you might have seen their son or their daughter or, their mum or, that's the best bit of general practice. We love that bit. We know our patients really, really well. And that holistic care, I think, means reduce number of unnecessary appointments, care close to home, reduce wait lists. Patients, if you ask them, would often far rather be in their local GP practice if they could get their HRT sorted out there or their contraceptive coil sorted out there or implants sorted out there than wait forever. Now, don't get me wrong, it's very important to acknowledge the role of sexual and reproductive health services and all that they play, particularly as well as delivery of contraception, but STI screening and that picture as well. And it's horses for courses. Some people may work in town. They might like to pop to a local sexual health clinic and get their pill and have their smear while they're there. That's brilliant. But it doesn't work for everyone. And also, particularly for our older patients, For example, if we're thinking about ring pessary changes, these sorts of things, many patients given the choice would like that care down the road in a GP practice that they know, with shorter waits, friendly face, and reduced number of multiple appointments. So I think they're so important. What we find in the research, some of the work that we've been doing at Primary Care Women's Health Society, and also NIHR have published a report on some of their work since the strategy on hubs so far. And what we find is a great deal of women's health care is still taking place actually in normal general practices without necessarily them being termed a hub, where there's that referral between practices, but it's about putting it in the community.
So how does your hub work, and how does it link in with local GP practices?
Yeah, so we have multiple hubs throughout Liverpool. We started in one of our PCNs, one of our primary care networks. We started inter-referral between a small group of practices. That model started to work well. We did it for LARC, so long-acting reversible contraception for implants and coils. Early on, we had a very proactive, innovative commissioner, James Woolgar, who's also chair of the National Group of Reproductive Health Commissioners as well, and has been very innovative in this area. He understood the importance of the joint commissioning very early on. We got that lined up, and he understood the importance of tariffs that were financially viable. Nobody's ever going to get rich. No one is ever going to make a profit, but it's about not losing money so you can actually just deliver that service without going under financially. So we started in one PCN and then very quickly replicated it across the vast majority of our PCNs in Liverpool. What we offer is implants and coils, and those coils are for all indications. So if it's HRT, gynecological indications, that's all covered. We offer some opportunistic smear screening and a few small smear clinics as well, opportunistic STI screening, and we offer ring pessary assessments, insertions and replacements. We also, throughout our hubs, have a few other pilots going on as well. We've got one PCN that's offers psychosexual counselling as well, and some sort of drop-in women's health queries, sort of any questions or queries regarding contraception. And we've got migraine and menopause pilot going on, and some HIV prevention pilots as well.
Do the practices within the PCN just refer into their hub, or can you refer to different hubs? Are there different hubs doing different things?
The majority of the services are inter-practice between most of our PCNs, where you can refer to a neighbouring practice which is in the same PCN, but we do have some cross-city-wide PCN referrals as well going on. One of the issues with that is access to records. So within PCNs, many PCNs down the country now since COVID and the changing way that we're all working do have note sharing, because of course we've got a lot of other projects now going on. The way funding comes in centrally to PCNs, and we've got services like ADHD and weight loss and other things going on. Other sort of care coordinators, care hubs, all these other things, social prescribers. A lot of these are staff, they kind of moonlight around the practices within a PCN. And so over time, PCNs have become more accustomed to sharing notes and records. When you cross the city, the functionalities there, I think this will be true. I mean, we use EMIS Web up here in Liverpool, and I think about 80% of the country uses EMIS Web. But even with other systems, I think we face the same challenges, that practices within the same PCN are just about okay these days, note sharing. But sharing whole city notes is fraught with a lot of data protection and other challenges, and not all practices want to do that. And the reason why I say that is we could today, if we wanted to, take patients from anywhere across the city. But I tend to encourage it to practice and facilitate that across all of our PCNs because of the importance of good access to patient records, continuity of care, just safety. One of the things really interesting that's changing there, I think, is more and more patients using the NHS app, meaning that we now can, if patients have downloaded the app, we now actually can get quite a lot of information for them. I really believe in good continuity of care, and particularly in the realm of things like HRT and patients with complex medical conditions, or they've had a previous cancer diagnosis. There's going to be an awful lot going on. You're really fishing in the dark if you can't see their notes, so that's really important.
Do each of the practices do bits, or, it's not like a physical building, it's within the practices, or is it just one practice that does all of it, and how does the staffing work?
Some of our PCNs have a dedicated building, but most don't. At least 2 of our PCNs have a dedicated building that where we have an area for the women's health, which is brilliant. We'd love that across the board. But as you know, the state is a challenge across the NHS generally. So those who are lucky enough to have a building, that's brilliant, because that then becomes sort of known as that Women's Health Hub location, staffed usually by staff who are already working within the practices, who, for example, are a LARC fitter or menopause specialist or ring pessary fitter, and they might have their half day a week where they do a bit of work in the PCN. And colleagues love that. They love having an area of specialist interest. They love being upskilled in that area. And I really think it helps with sort of morale and career retention, and colleagues just enjoying having that specialist knowledge. So most of our hubs, a couple have designated buildings, many just use rooms within different practices within those PCNs. We will have allocated rooms that are used, and then they'll be staffed largely by staff from already working within the PCNs. But some of our PCNs have started to form their own staff banks, where there's a bit of continuity and colleagues who are well respected and got the credentials and starting to have regular work directly within those hubs.
What are the benefits for patients? Does it mean that they don't have to wait so long, or is it just because it's on their doorstep and where they're familiar with? Is that the big benefit?
100% it's shorter wait list. I think across the city, nobody's waiting more than 3 or 4 weeks for a procedure or appointment, particularly for the LARC and the ring pessaries. Closer to home, patients haven't got to get, a couple of buses across the city, often seeing a friendly face, often, maybe somebody they might know from a surgery. For example, in the procedure clinics, a lot of our staff that assist the clinics are nursing associates or HCAs that often work in the practices. So they often are the ones that really know the patients. And obviously, there are times when we never want to operate outside our skill mix or our qualifications. And if a patient needs to be seen in secondary care, they need to be seen.
Are you effectively commissioned by the ICB for each of those things, and then you get a funding stream for each of those things?
The vast majority of our funding is on what's called like the LES agreements, the locally enhanced service agreements. So
Yes, yeah.
for the commissioning for sexual and reproductive health, many areas have a LES agreement with primary care practices where there's set tariffs. So it's kind of activity-based income. Most of our income is built around that, where we get income for those LARC procedures, and we get income in the same way we have a pessary les as well. We have a small inter-referral fee, which our commissioner added in just to incentivize practices to see patients outside their own practice. It's limited. It's really commissioned by for us in Liverpool, it's commissioned by the local city council who hold the purse strings for the sexual and reproductive health. The vast majority does come from the public health budget. I still, to this day, would really love more conversations around moving out some of that left shift that we're always talking about for what we think could be done, particularly like the menopause care, I think is an easy win, because we have so many qualified colleagues now out there in primary care who are registered menopause specialists or have done further menopause certificates, but they're just not able to be paid a thing for using those specialist skills. And I've even known colleagues recently have to give up their advanced certificates because just not seeing enough patients, because they have to do the work that their practices send them. Your usual clinic obviously needs a must. I think it's a real shame, because if you look at those equivalent HRG codes in hospital, you're talking sort of 300 plus the wait list, plus the burden on the system. When, we've got some highly skilled menopause specialists out there in the community and able to use those qualifications.
How widespread are women's health hubs? Are they everywhere now, or is it something that still needs more work?
They're not everywhere at all,
Yeah.
truth be told. They're often talked about because I think it resonates with people, the concept, the sort of one-stop shop. And the vast majority of women's health, and this is women's health over and above the GP spec that we could deliver in primary care with clinicians who've got those qualifications. The government, when they removed women's health from the NHS planning and guidance in February 2025 last year, they sort of touted the statistic that 93% of ICBs have enabled a women's health hub. It sounds good on paper, but it really is just a misleading statistic. One women's health hub, to me, it's a bit like saying there's one corner shop in central London. The majority of ICBs have established a women's health hub. Well, that could have been covering a few hundred women. There was no clarity on exactly how many women have access. And so women's health hubs aren't common at all. Most areas have got the odd GP who's going above and beyond, squeezing in a coil at their end of a busy clinic before they rush off and do a home visit. But there's still a huge postcode lottery, and those services aren't being protected and ring-fenced. If anything, I think they're coming more under threat since women's health was removed and no more money's come down. So I think we've barely begun. I think now we're under more and more pressure than ever in primary care. And I've got colleagues who have been trained with some of those skills and they're just not able to use them. Colleagues in practices increasingly becoming more under pressure, really, not able to ring fence and protect that once a month coil clinic that their practice manager and partners let them do because they know it's their interest. And yeah, okay, it doesn't make us any money or it might even lose something, but we know it's the right thing to do. But goodwill will only go so far.
Yeah, absolutely.
Early on, there was quite a bit of optimism that more support was coming. So there was a lot of enthusiasm for training and for PCNs and areas to focus on women's health hubs. I think we're going to have a very difficult year ahead, personally, knowing that there is no more coming centrally from government. ICBs are very, very busy focusing on, outpatient transformation, elective recovery, all these things. My personal view is if we sorted out these services, we would reduce the burden on emergency services and women going in with heavy bleeding to a gynae ER or patients being admitted.
The other thing I know that you're really interested in is reducing health inequalities. How do you think health hubs can help address health inequalities women experience?
We obviously got posters in different languages. We use the language lines in order to make those consultations available for all. I think it's always a challenge that there are, a lot of voluntary sector folks out there working particularly in those hardest to reach communities. And if there are not just language barriers, but often stigma, there can be stigma around contraception, there can be stigma around an intimate examination. There's also so many factors to consider. And I think, there's always more to do in that area. But we do pride ourselves in trying to make our designated women's health areas, accessible to women of all different ethnic backgrounds and language backgrounds. But there's always more to do.
As a GP with a special interest in women's health, is there any advice you'd give them if they were looking at trying to tackle health inequalities that women experience? Is there any area they could focus on?
We definitely know that areas like menopause are less well addressed in certain ethnic groups. We have to, understand for some cultures, it's normal to chat about hot flushes. For others, it's more taboo. And there is a wealth of material out there, free posters, and these days using a lot of social media and through those channels. Again, you're always going to hit some nails on the head and miss others with different things, aren't you? Because not everyone's tech savvy. There's been a lot of, you may have come across things like the Menopause Cafe and other events like that. I know across the city here in Liverpool, there's been some events particularly aimed towards more of our ethnic diverse populations, just going out there into the community, discussing some of these tricky women's health issues and taking folks with the knowledge and the skills to be able communicate to those populations with getting on everyone's level, isn't it? And getting those messages out. I think it's always a challenge. Language barriers are a challenge. Menopause can present differently in different ethnic groups as well. In Black and Asian groups, slightly different, slightly earlier menopause actually, but also different symptoms. So I think there's an education piece for us as clinicians. And then there's the patient education to empower people to know how to seek more help. And then there's always that sort of earlier on in life, that education piece from sort of school upwards.
Finally, I just wanted to ask you a little bit about screening and early diagnosis of cancer. I mean, do you think women's health hubs could be a bit of a game changer in terms of boosting uptake of screening?
100%. For example, the cervical screening world has changed massively recently. We've had the shift to 5 years, and then we're seeing all this innovative technology coming out at the minute, things like sampling the blood cells from like a sanitary pad. There's all sorts of new innovations coming out right now. 100%, I think that the Women's Health Hub model is a great way for us to roll out more screening. The challenge we have is we need the monies to flow. We need ICBs to recognize what a gift these models really are. And we need interface, partnership, collaboration, and integration is what we need between primary and secondary care. It's not somebody being the boss of someone else. It's let's work together, let's get teams around, and let's put patients at the center of it. And I really, really believe that that model of getting our heads together between primary and secondary care could save so much strain, both in the primary care end, but also in the secondary care end. I think if we could help each other. My wish would be if there was more top-down leverage, steering, incentive, whatever it takes, stick, carrot, whatever, for ICBs to have to be shown to use their resources wisely. And some of that involves accountability for what's spent where and why. If you've got X number of hormonal coils being fitted in secondary care, we need more questions asked. Why can we not move these out, save some money on the system, and everyone's a winner? And it might not even be, I'm picking up block contracts, even like subcontracting can work. I think there's lots of ways to do it. The ICBs have got a lot on their plate. They've got a lot of challenge to deal with. We just fall to the bottom of the pile with the community women's health stuff, whereas I think we can help solve the problems higher up.
It could be a really good focus area for neighbourhoods as well. I mean, it seems like an absolute sitter to be able to take some of those services out of hospitals and into the community. And like you say, there's lots of GPs who have the skills to be able to do this if they had the resources to do it properly.
100%. Leslie Regan did some work recently looking at one particular ICB, and they said, 70 to 80% of referrals coming in didn't need to necessarily see a hospital consultant, because they were things that didn't need an operation. The solution is sitting right in front of us, but we have to be careful now that we don't just do more and more and more with no resources at all. Where there's a will, there's a way. Sometimes out of real desperate need, solutions can be formed. So I know at times I'm a little bit critical of just how hard it is to build these services. I do believe the solutions are there. I do believe we've got workable solutions, proven solutions. We really need everyone around the table, and especially we need ICBs on board. And if there's no more money coming, then we have to say, right, what can we spend more wisely in order to free up income so that everyone's a winner, so that, everyone gets a piece of the pie. And I do think those solutions are there.
Well, that's a really positive note to end on. So thank you very much for coming on the podcast, Stephanie. It's been really great to talk to you. I've really enjoyed it.
Thank you for having me. Thanks, Emma.
Well, that's it for this week. Thanks again to Stephanie, and thank you for listening. We'll be back soon, but in the meantime, don't forget you can keep up to date with all the latest news and access lots of other resources on our website at GPonline.com.